hi, a big warm welcome to all the delegates who have linked into the first ever BAUS CESR course. With me, I have my colleague and course director, Ms. Mevash Nadeem from James Cook University Hospital, and I'm Mr. AJ Pahuja from Belfast City Hospital, Northern Ireland. Why did we choose to do this course? It was as part of the project SAS and support of BAUS and President Tim O'Brien. We felt that there was a need for such a course for aspirants, non-trainees who are wanting to pursue a career in urology and become consultants and progress in the NHS. So we have a great faculty, and my colleague will introduce them later. But the main objectives of this course, we felt, were it'll help the candidates gain information about evidence collection, talk about the key changes in the new ISCP curriculum. There will be practical guidance on the actual application process. And at the end, we have an open forum with a question and answer session of the common pitfalls and some of the tips to complete the application process. Hope you enjoy this first ever course. We would love your feedback to try and improve this, and hopefully we can run this on an annual basis and help as many candidates as possible in the future. I will now pass this on to my colleague, Mevash.
Thank you very much, Ajay. It's a great pleasure to be part of this course. Ajay has given a bit of background of why we are doing this course. We have some excellent faculty members on this course today who are going to touch upon some key issues from GMC, JCST, and SAC perspective. We'll have the opening remarks from Mr. Nitin Shrotri, who is the chair of the BAUS SAS working group. And then we will have an excellent presentation by Professor Philip Conford, who is the SAC chair, and he will be talking about what an assessor looks for in the CESR application, and he will particularly touch upon the changes in the new curriculum. We have also invited Mr. Mark Johnson, who is the CESR casework manager from JCST, and he will talk about where the CESR application shortfall. We will have Ms. Tista Chakravarti Gannon, who is the head of outreach, development, and support operation from GMC. She will be talking about the culture and fitness to practice issues. You will see Ajay and myself alongside Mr. Ashwin Sridhar in the open forum, and we will be answering as a panel to most frequently asked questions. And these questions have been collected from various forums and those who have been asked to us personally, and we'll try our best to answer those questions. We'll then take some closing remarks from Mr. Cresswell, who is the Vice President of BAUS, and Professor Ian Pearce, who is the BAUS Secretary-elect, and then we'll bring it to close. Hopefully you'll enjoy this course, and we will look forward for your feedback. Thank you very much.
Project SAS has been started with the support of Tim O'Brien and BAUS. This is mainly for the benefit of SAS doctors who have often followed a lonely pathway to success. And many of them have. They have shown motivation and courage, apart from being good surgeons. The CESR course, which is being started today and is being led by Mevash Nadeem and Ajay Pahuja, is meant to offer support and guidance to those of the SAS colleagues who wish to take it up. I think it will also be useful for trainers to have a look at this, because they will then be aware of what the SAS colleagues need to progress in their careers. It's very important that we support each colleague in progressing in their own careers. Congrats to Ajay and Mevash for setting this course up. I wish the course the very best. Thank you.
Thank you very much for asking me to be part of this teaching course about CESR applications. Our presentation will be divided, not quite evenly, into two parts. First, what an assessor looks for in a CESR application, then how this will change as a consequence of the new curriculum. So perhaps we might start with what is CESR. It is a certificate of eligibility for specialist registration, and it's the application route for doctors who've not followed a standard UK training programme. It's assessed against the same standards as the UK CCT curriculum, and it's evidence-based. It is not an assessment of competency in your current role, and it's not based on because my mates say I'm a good chap. Why don't I get a CCT? Well, originally that was based upon a decision from the European Union. This was designed to discriminate on the basis of those who'd been through a formal training programme, and a CESR might not be accepted outside the UK. However, within the UK, there's no difference in the recognition of a CESR and a CCT. So, in order to apply, you actually need relatively little minimum information. You need a specialised medical qualification in urology or 6 months of continuous training in urology. All applications are made via the GMC online. Once it's started, it needs to be submitted within 12 months. You can see that it's not cheap, and this price continues to go up. CCT is actually very regulated by law. The Medicinal Act is actually what allows people to act as doctors, and there are a number of subordinate legislation describing how it's to be done, which are listed on the slide. All of these bits of legislation are having to be updated after Brexit, and many are not yet complete, and we may yet see changes as things progress. So, CESR. It's done online, and you can see here is a flow diagram of roughly how long it takes. You can see it's not a short process, and it needs to be planned. There are guidance about how long you can take in order to do the different stages, but the only bit which is actually firmly regulated is the 3 months from an approved application reaching the college and the issue of a declaration. So the GMC can really take as long as they like, but the SAC and the JCSD have a fixed time. Before you apply, look at the available guidance. There is quite a lot of guidance out there. It's on the GMC website, and you need to read the curriculum, because remember, you're going to be assessed against the curriculum. If you don't have the evidence, don't rush. Wait until you can get it, and make sure that it is relevant and organised. As an assessor, if it's difficult to find stuff, we're likely to say it didn't exist. And remember that evidence needs to be from the last 6 years to show that you're currently competent. And 6 years is because, well, for training, you get 5 years to train and 1 extra year of remedial training if required, which is where the 6 years comes from. You can see there that when you look at the amount of information required, most effort is put into domain 1 smaller amount into domain 2, and domain 3 and 4 require less evidence. Remember that the evidence that you submit needs to be verified. You'll need to identify somebody at each institution you've worked at where, if we're prepared to do this, they'll need to complete the pro forma. Their identity will need to be checked, and then they will submit pro formas with the application evidence, and there'll also need to be primary source verification. So again, if some of your evidence is from overseas and you start the process off, you'll really put yourself under pressure to get it. So being organised is perhaps the number one skill required for getting through this process. When you apply online, it'll see something like this. You'll be able to add and delete documents. That will build up your portfolio. The first bit is just really an eligibility check. And from the time that's received, they should issue a checklist in about 30 days. During that time, they'll look at the structured reports, they'll contact the verifiers, and they'll look for hard copy evidence. So when you're looking for structured reports, you need a minimum of 4 referees whose evidence will be used to compare with your primary evidence. It doesn't replace anything. It's just there for triangulation. And remember that your first or main reference needs to be your current medical or clinical director, and you must include at least 2 urologists. Look for people who can comment on your current competency, the breadth of your practice, and your personal attributes and skills. Again, precise is better than verbose. What we're looking for is people who will support your skills and attributes. When the evidence is in, a GMC applications advisor reviews the evidence. And largely, this is about checking it matches, and it will create a checklist for you. At that point, you have 60 days to gather further additional evidence if required. And the GMC will then verify that additional evidence once it's all in. Remember that if they write to you and say you're going to need to submit evidence about this, it's very unlikely that the assessor will make a different call. In fact, I don't believe I know that's ever happened. So what you're looking for is to take this feedback and act upon it to make sure you have the best chance of getting through this process in one go. You'll get something like this, a document summary, which shows what's been accepted and what hasn't. And that should tell you how likely or otherwise you are to get approval. So then there's an evaluation. So evaluations are done independently. They're done by members of the SAC, but the GMC is there to do quality assessment of our evaluation, but it is likely to issue a decision based upon the, in this case, Royal College of Surgery's recommendation. Again, it's worth stressing, the evaluators are not paid. You are paying a lot of money for this. It goes to the GMC and to the college, but the evaluators are not paid for this. And so try and make it as easy for us as possible. We often there might be 3 or 3,500 pages of information you've uploaded, and I'm going to spend all day one weekend trying to wade through to try and work out whether it is there or not. If I get fed up, I'm likely to say, I couldn't find it, he doesn't have the evidence, because it is actually for you to prove you have the evidence, rather than for me to hunt through everything to find it. Success. So, success has been reasonably stable. If anything, it's gone up a little bit over time. This is for all surgical applications over the last few years. You can see there's about a 50% chance, or just slightly higher, of having a CESR granted. So where are there problems? Well, there are problems, and perhaps the most difficult one to overcome is if you haven't passed the standard test of knowledge within the curriculum. Now, you can try and demonstrate equivalence, but it is very difficult. So the standard test of knowledge for urology is FRCS Uro. And I would say, if you haven't got that, you are really going to be struggling to get a CESR. There was a case recently where a reasonably well-known professor from continental Europe was keen to have a CESR. He had published in many fields, and I spent more than 24 hours tracking through the curriculum in order to try and match, to show that he had the knowledge throughout the curriculum. And I couldn't. And I think for most of us, we would really struggle to show the standard test of knowledge any other way than passing the exam. If you haven't collected WBAs, or you collected them a long time ago, or your evidence is out of date, that's probably the next most likely reason for getting rejected. And again, we're looking for personal involvement in audits. So if your name was tacked onto the end of something that the core surgical trainee did, at least be able to understand something about the audit and to be able to show how you were involved either in initiating it, in deciding what data should be collected, or in working with them to make a change. Because that's really what matters. Lack of evidence of research is not an unusual reason, but I think there is more laxity about that. Please remember that we won't count things you've paid to have published. So increasingly, we see people who've paid large sums of money to publish an article of dubious scientific benefit to try and hit this target. It costs you a lot of money and we're likely to reject it. I think it's also fair to say that a case report doesn't really show an understanding of research. So again, that's likely to be rejected. The thing that upsets people most is if they get rejected because of subspecialty practice. So if you run a tertiary centre doing robot prostatectomies, it's unlikely that you are up to date with paediatric surgery, incontinence, or even stone disease. And as a consequence, you'll get rejected. not because you're not capable of being a consultant, but because you don't meet the criteria for a CCT. And lack of management and leadership experience does turn up, but often it's a lack of showing how you were personally involved and what the outcomes were that drives the problem, rather than because you've not got any experience. Many of the people applying for CESR are experienced clinicians and do have this, they just haven't been able to demonstrate it. So, outcomes. If you're successful, specialist registration is granted and a copy of the evaluation is sent to you. I can't imagine anyone reads it. If you're unsuccessful, a letter confirming that is sent. It is also along with options for renewal or appeal. You'll get a copy of the evaluation, and it will include recommendations which will help in future applications. Future applications are often worth the effort, because in some ways you've been given guidance to show exactly what it is that we thought was missing. You can apply for a review if you've got additional documentary evidence. You can if there's a procedural error. But again, in the 7 or 8 years that I've been doing this, I've not seen a successful claim based on a procedural error. If it was entirely down to me, I think there may be more procedural errors. But Mark Johnson's going to talk to you in a minute, and the team at the JCST that run CESRs are incredibly thorough in how they handle the information and make it work. And on that basis, procedural errors are most rare. If you do decide to apply for a review, you have to do it within a year. And often there'll be something we have suggested that is appropriate. You can go away and do it, get that signed off and come back. There is, of course, a review application fee, but it's smaller than the initial fee. And the reason I think review is worth considering is this. You can see that an ever-increasing number of the people who review an application are successful. Now, that will be because some people don't review an application. But if you've got new evidence and you can show that you've completed the pieces we asked for, then it is quite possible for you to gain your CESR. I also think this shows that people who have historically done CESR applications haven't been incredibly well advised. We haven't changed what we want. It hasn't changed for a long time. And on that basis, it ought to have been possible for people to be able to collect the information required and submit it first time and save themselves the extra £700 and something for a review application. It's expensive not getting it organised first time. So, how will the new curriculum impact CESR? And why will it? I'm going to spend the next 10 minutes or so just trying to explain what the difference is, how that change will happen, and trying to make people aware of what they can do to improve their chances. This was the original GMC statement when the new curricula were published. And the reason that it changes is because you are being assessed against the current curriculum. And if you're not up to date with the new curriculum, you will be failed even if you would have been up to date with a previous curriculum in the past. That's worth thinking about, and particularly because on this occasion, because there is such a big change, the GMC have accepted that even in August, when we move all the trainees across to the new curriculum, they will continue to allow people a choice of whether they apply under the new curriculum or the old curriculum up to August 2023. So there is time if you think that you were considering it. So this is where the change is happening. This is the new curriculum, which I helped write, and it is going to incorporate new areas which people will need to be able to show their competence for. Mainly because it was clear for people at fitness to practice hearings that they were failing to achieve generic professional capabilities. This is what we mean by that. They are in effect the underlying principles by which medicine is practiced in the UK and really across the world. It is the expectations that we all have if we as a patient were to go and see a doctor. And they've now been written into the curriculum. And because they're part of the curriculum, you will need to be able to show that you are achieving this. And in fact, they are equal in importance to the knowledge and skills we traditionally measured. Now, there are a large number of descriptors which have been developed so that you can look through the 9 generic professional capabilities and ensure that you are achieving them. In addition to that, there are capabilities in practice. We want to know that you can do these 5 things. Manage an outpatient clinic, manage inpatients and ward rounds, cope with the emergency take, do an operating list, and work in a multidisciplinary team. And again, on the ISCP website, there are a number of ways in which you can be assessed to show that you are achieving this. But even the assessment is changing slightly. What we're looking for is how much do I trust or need to supervise my trainee in any particular capacity? And if you're not independent, what needs to happen to make you independent? And there are 5 different supervision levels. We will expect a day 1 consultant, and therefore anybody applying for CESR, to be at level 4. The curriculum hasn't actually changed. The syllabus and the information required is unaltered. But what the GMC has been keen for us to introduce is a number of critical conditions. These are felt to be important for patient safety, and you will need to be able to demonstrate, either by CBDs or KEXs, that you are capable of managing them. And in addition, there are a number of index procedures. In many ways, I think this will be easier for people applying through CESR. There isn't quite the same breadth of knowledge required in PBA. There won't be that hunting down the last PCNL, although you never do it. But you will need to be able to show that you are currently capable of performing urodynamics, doing a prostate biopsy, resecting a bladder tumour, surgery for bladder outflow obstruction and ureteroscopy and laser, and scrotal surgery including torsion. And you'll need to have at least 3 PBAs by at least 3 assessors for each of these things, so that's 9 in total. The critical conditions, they are things where misdiagnosis could be truly dangerous or have devastating consequences for life or limb. And in urology, it's these. And again, I think this will be slightly more challenging going forward. You need to be competent to manage renal trauma. You need to be competent to manage an iatrogenic ureteric injury. And level 4 means without a consultant in the room. And you'll need these to be signed off in the same way that you will need to be able to sign off the procedures we talked about. And I think this will probably be slightly more challenging. And then in addition, we're looking for people to have some form of special interest. I think this will help people doing CESR, many of whom have an interest in one of the topics here and are already able to do one of the things that is listed. And I think this will stop people hunting around for things that they no longer do. And lastly, it will be supported by the multi-consultant report. There is a special blank multi-consultant report available on the GMC website, and if you're considering CESR, I think you should look at it. But it will assess whether you are competent. And by multi-consultant, we want more than 1, ideally a minimum of 3. For extra information, look at the specialty-specific guidance produced on the GMC website. These are the different areas that we will be asking you to consider. And remember that SIPs and generic professional capabilities are going to appear as part of Part 3 and Part 4 of this application. When you get to do a multi-consultant report for CESR, ideally it should cover the last 6 months prior to making your application. And I would suggest that you create a learning agreement at the beginning of this procedure, which might be included as part of your PDP. Have a formative assessment halfway through the period, and then a summative assessment you can submit at or just before the time of submitting your evidence. For more information, look on the JCST CESR webpage, and remember there are links to documents for the multi-consultant report for CESR, advice for applicants, and for your consultant raters on how to perform this for CESR. And it's also an example of a completed form. I hope this information has been useful. Thank you for your attention.
Hello there, my name is Mark Johnson and I'm one of the CESR casework managers based at JCST, and I've been asked to come along and have a chat with you as I know you're either thinking about applying for CESR or are busy collecting evidence for your application. My job involves receiving the evidence from the GMC and then putting it together as a sort of roadmap for the evaluators to look at. It then gets sent to 2 evaluators who review the evidence, which then gets sent back to the GMC with their recommendation to enable the GMC to make their final decision. Over the years, we've identified a number of instances where applicants have regularly failed a particular section, and what I'm hoping to do is to highlight some of these so you don't do the same thing, as well as giving you a few tips and things to think about along the way, which hopefully will help you towards a successful CESR application. The CESR process has been designed by the GMC to show equivalence to the UK curriculum that applies at the time of application. So you need to demonstrate that you've gained the competencies originally, as well as showing that you're maintaining them. To this end, we're specifically looking at evidence from the last 6 years, which is considered to be recent. There's actually quite a lot of information on the web about applying for CESR, but initially you should go to the GMC's website to look at the curriculum that you'll be applying under, which will give you a detailed idea of the scope of what you need to provide as evidence. Also on their website, you'll find the specialty-specific guidance, which has been put together by the GMC in conjunction with JCST and the SAC, and follows the same order as the GMC's application form, basically setting out what you should be providing under each of the sections. JCST have also written a set of guidance notes for CESR applicants, which is available from the CESR pages of the JCST website, which also contains the CCT certification guidelines. I'd suggest that you bookmark some of these. When I'm preparing a case, I use them to check the evidence provided against what the requirements actually are, and you can also use them as a checklist for your evidence. When you apply to the GMC, you'll be allocated an advisor who will guide you through the evidence collection and answer your questions, and JCST are also available to chat through any queries you may have, although what we can't do is a pre-application assessment. One of the other suggestions we make is that you try and find someone locally who you can bounce ideas off as to the best possible evidence that you can provide. When you apply for a new job in whichever field you're working in, you have to send in a CV detailing your experience, and it's recommended that you try and tailor your CV to bring out the experience you have that matches the job description. And a CESR application works in a similar way. When you're putting your evidence together, consider the best ways of presenting this to the evaluators so that it's clear and concise. Remember that CESR is designed as an equivalence process, so there's many ways of presenting the evidence. We'd recommend using eLogbook to demonstrate your total numbers and indicative numbers, and ISCP is a good way of storing your workplace-based assessments, which enables the evaluators to see clearly how you've completed the procedure, together with the trainer's comments and reflections. The evaluators will be looking for primary evidence in each situation. This is the best available evidence to demonstrate a particular item. Secondary evidence is one step removed from the primary source, and whilst it can be useful in providing details of background and environment, it won't substitute for primary evidence. We'll look in a bit at examples of this and how a well-chosen piece of evidence can cover a number of requirements. Also, consider how you're structuring your evidence. Don't assume that just because you've uploaded evidence in one section that it'll be looked at in conjunction with another. Make sure you cross-reference details, i.e. presentations relating to audits that you may have uploaded in research. Similarly, try and ensure that the evidence provided is consistent. Make sure the uploaded evidence is fully visible, easily readable, and doesn't change orientation or rotation after every document. Some uploaded documents, such as photos, cannot be searched for using a word search, so ensure anything important is cross-referenced as above. This slide gives an idea of some of the regular reasons why CESR applicants fail. As you'd expect, a lot of them fall within domains 1 and 2, and in a lot of the cases, the applicant has either misread the requirements or forgotten to include items, or in some cases not appreciated what is actually involved. What we'll do now is we'll have a look at the individual domains, and I'll hopefully give you some tips and hints, things to look out for or provide, and some easy wins. Knowledge. As mentioned, a CESR application should demonstrate equivalence to the UK curriculum. Consequently, there's only one exam that completely matches the requirements, and that's the one that tests specifically against the curriculum, which is the Intercollegiate JCIE FRCS exam. No other exam on its own covers the breadth and depth of the curriculum. However, as I've said, CESR is an equivalence process, So if you don't have that particular exam, what we suggest is that you put together a portfolio of evidence to demonstrate how you consider your evidence, including exams, research, etc., covers every aspect of the curriculum. We'd recommend that you provide a mapping exercise showing what you've done and how this covers the curriculum. This is actually quite a mammoth task and can be quite difficult, which is why I'd recommend reading through the curriculum at the outset so you get a fuller idea of what's required and what needs to be covered. You need to consider everything in the curriculum, so simply matching PBAs to a few of the topics will not demonstrate the breadth and depth of the curriculum. You may find the GMC's specialty-specific guidance helpful here. Moving on to skills and experience, the urology CCT requirements detail the indicative numbers required for the specialty. Remember that these are the indicative numbers to determine safe practice. So providing more of one procedure in the hope that it'll compensate for a deficit in another may not work. We recommend using the e-logbook system, as I've said, as this sets out the evidence clearly, but don't forget that we're looking at the last 6 years to show that you're maintaining your competencies. Ensure the report covers what you expect it to. In particular, does the report date range cover the details you're expecting? In a recent case, an applicant left the date range filter blank so that it will bring up everything they'd entered into the system. But unfortunately, in entering that data, they'd transposed the digits for a particular procedure, so instead of a year of 16, it was showing 61. This meant that the summaries were showing as being from 1961 to 2021, so the evaluators couldn't tell what had been achieved in the last 6 years. This is one of the most important aspects of a CESR case, as this is an indication of how you're currently practicing. Again, the CCT guidelines show the level of competency you should achieve for each particular procedure. Make sure you include a number of assessment forms at the right level and signed off by different evaluators. We recommend 3 PBAs by 3 different evaluators, as this triangulates the evidence nicely, and they should include feedback from the evaluators and your reflections. There's guidance available as to how they should be presented, and there's a few things to bear in mind when you're putting them together. Firstly, if they've all got top marks without comments from either party, they're less meaningful, and they shouldn't be respective, so there's no value to compiling PBAs now for procedures you've done 3 or 4 years ago. Make sure the PBAs are the best ones you can provide, so don't include ones where you're only partially involved, and ensure what you provide makes sense. If you tell us, for example, that no elective surgery has taken place for some time, and then suddenly provide 24 PBAs from a month later over 2 days, this is likely to be queried. We'll also look for evidence of having been exposed to a wide range of urological subspecialties during training, including a wide range of emergency surgery. This should include a minimum of 40 days of paediatric urology exposure. Most of the rest of the domain is fairly straightforward as long as you consider the guidelines available. With regard to CPD, we're looking for evidence of attendance at at least one national or international congress every 2 years. There are also a number of recommended BAUS approved courses such as urodynamics and paediatric urology. The urology requirements for research are quite specific and again are set out in the CCT guidelines. At present, the requirement is for 2 presentations, podium or poster, as first author at regional or national meetings from work undertaken in the last 6 years. In addition, there's a requirement for a number of publications which is split into 4 separate alternatives. You only have to match one of these, but it's helpful if you could indicate which of the alternatives you're providing evidence under. As usual, we're looking for you to demonstrate currency, so you need to ensure that your publications and presentations demonstrate your current involvement in research and are from the last 6 years. Albert Einstein said, "If we knew what it was we were doing, it wouldn't be called research, would it?" So always remember that we're looking for significant evidence of research, so a case report or collaborative article may not particularly demonstrate this. Make sure you indicate what your actual role in the research was, as this may not be immediately apparent from the list of authors. There's also a requirement for a GCP course in research governance and a research methodologies course. Whilst there is some overlap, you should ensure that evidence of completion of both courses is supplied. This ties in with a number of other sections, including CPD, Teaching and Management, and Leadership, where specific courses are required. For example, in the case of training the trainers, we know there are a lot of courses, both physical and online, but not all of them cover the education theory behind successful teaching, which is what we're looking for. This is recommended to have been taken in the last 2 years to ensure knowledge of up-to-date teaching methodology. It's worth noting that some courses are designed for specific specialties or course tutors. In other specialties, for example, there's an ATLS instructor course or TTT for colonoscopy trainers. So these courses may be skewed towards that particular course or specialty and miss some of the broader aspects. If you're in doubt, add a copy of the programme that you've attended so the evaluators can see what the course covers. The one course that is regularly missing in applications comes under the heading of Management and Leadership. As with TTT, there's a lot of courses covering these aspects, but a lot of them only cover the individual's leadership skills. And the curriculum also indicates a need to have knowledge of the management and structure of the NHS, so it's important to ensure your course covers this. Again, if you're unsure, send a copy of the programme for the course in with your application. Again, it doesn't have to be a single course, so you could have one covering the management aspects and one covering the leadership. As an aside, we know that training has suffered a bit over the last year or so we're trying to be fair about things and are coming up with suggestions which are shared with the GMC as to how to show equivalence. As an example, some other specialties require a valid ATLS credential, but if it's expired, you could demonstrate how you're keeping your trauma competencies up to date by means of a number of relevant CBDs. However, I'm not aware of any specific queries relating to urology at the moment. Teaching and Assessing is another program where people regularly fail, usually due to applicants not supplying sufficient information for the evaluators to make a decision. Broadly speaking, we're looking for 4 specific types of evidence. Number 1, teaching timetables and certificates to demonstrate that you teach regularly and over a number of subjects. 2, copies of lecture slides, handouts, etc. to demonstrate how you teach. 3, feedback from those taught. We're particularly looking for feedback from trainees here. Whilst observation of teaching forms from colleagues gives some idea, we're looking more at how your trainees view the content and method of your training. Ideally, we're looking for individual session feedback, although course feedback is acceptable if the evaluators can identify the relevant teaching sessions. And number 4, evidence of assessing and appraising others. This could be acting as an examiner, as a member of an interview panel, or completing WBAs for trainees. Lastly, in Domain 1, we're looking for evidence of making appropriate referrals and record keeping. We often have people fail because the evidence they provided are letters to them rather than the referrals they're making to other people. You can also cross-reference to other examples of communication with colleagues here. Moving on to Domain 2, the first section we look at is to do with audit. With urology, applicants should provide evidence of 3 audits, one of which must be a complete cycle, and 1 quality improvement project. Note, though, that an audit and re-audit will only count as 1 audit, not 2. In general, be clear as to when these audits were done, why, and what the outcome was. It's helpful if you could indicate what you're including under each requirement, and you should ensure that each of the audits is a true audit rather than, for example, a service evaluation. And again, remember to cross-reference with other sections if appropriate. Governance is another of those sections which applicants fail, often for the same reasons. I've mentioned the requirements of the management and leadership courses previously, but this is a good example of where a well-chosen piece of primary evidence can cover a number of sections. So initially, we're looking for evidence of regular attendance and involvement in things like MDTs, M&M meetings and governance meetings. Now, a lot of applicants just provide a letter from the trust saying that Dr. X attends MDT meetings and so on. This is secondary evidence. So what we're actually looking for is actual evidence that this has taken place. So well-chosen copies of sets of minutes will not only confirm your attendance, but can also demonstrate your involvement, whether by means of a presentation or as taking part in the discussion. If you've actually chaired that meeting as well, that'll be a good example of leadership skills, which you can use in Domain 3. We're then looking for a role that enables you to demonstrate how you've been involved in the management side of the hospital or trust. Over the years, the most regular examples we get are where people have been responsible for rota management, or have been a trainee or junior doctor representative on a committee, or have been involved in a specific working party. Again, make sure that the evidence is clear. For example, don't just send copies of the rota, include correspondence that demonstrates your involvement. Appraisal's fairly straightforward, and we're basically looking for two things here. One is engagement with the actual process itself, which is why we're looking for at least 3 cycles. And the other is to ensure that you're actually responding to what's discussed at these meetings. So ensuring the appraisals contain a review of the previous year's PDP, together with one for the forthcoming year, can help identify this. The last part of Domain 2 is concerned directly with personal safety, both your own and that of your colleagues and patients. In terms of the latter, your referees will provide secondary evidence of how you demonstrate this in your day-to-day practice, but we'll be looking for primary evidence of your commitment to this. So evidence of training in things like infection prevention and control, or safeguarding adults and safeguarding children. An ideal way of demonstrating this would be by providing a copy of your trust mandatory training record, which not only would demonstrate completion of such courses, but can also be used to demonstrate things like information governance and equality and diversity in Domains 3 and 4. With regard to your own health, any primary evidence you can provide will help bolster the comments of your referees. Applicants often provide a copy of their immunisation history, which demonstrates how they keep their personal health under review. Domains 3 and 4 are the 2 domains which are easiest to meet, and with some well-chosen primary evidence, you may already have provided sufficient to meet some or all of the basic criteria. The first part looks at communication with both colleagues and patients, so some of the evidence you've already supplied as part of Domain 1, such as copies of referral letters and other correspondence with colleagues, will also be relevant here. We'll also be looking for evidence of your communication with patients, so letters to and from patients and thank you letters will cover this. In addition, you may have provided 360-degree feedback as part of your appraisal evidence, which we can use to look at your communication skills both with colleagues and patients. For teamwork and leadership, we're generally looking for wider evidence than that of leading an audit. So, as mentioned earlier, you can provide evidence of meetings that you've chaired or other projects that you've instigated, led on, or worked on, potentially together with your involvement on MDTs, etc. We'll also be looking for a leadership course here, which, as I said, may or may not be different from the management course listed in the governance section. Make sure you keep this relevant to your job. One of my first cases, we got lots of details about a local football team that the applicant was leading, which was quite interesting, but not really relevant to their role in their trust. Lastly, in this domain, we're looking at the partnerships that you establish with patients. So part of this will be covered by the communication evidence referred to earlier in the domain, but we're also looking at your role with regards to the consent process and how you use your skills with patients and their families. So if you've completed courses on the different types of consent, it's probably worth including details of them here. Finally, in Domain 4, we're looking at how you manage to gain and keep the trust of your colleagues and patients. A lot of this information will come in secondary evidence from your referees, colleagues and patients, but in particular we're looking for primary evidence of your knowledge of information governance, data security and equality and diversity or similar subjects to show how you look after people's data and how you treat them. As I've said earlier, a copy of your mandatory training record, which you may have already provided, will cover this. So what happens next? Now you've got to the stage where you've presented the evidence to the GMC and you've decided to authorise them to send the case to us. As I've mentioned at the start, we then send the case to the evaluators and we've got 7 weeks to send them back completed to the GMC, who will make the final decision. It's very rare that we go outside this deadline, and it's usually only a matter of days. The evaluation will be effectively in two parts. The first part is the actual evaluation, where the evaluators look at the evidence and consider whether the evidence you've provided meets the standard required, or perhaps needs strengthening, or is missing something. The second part is a list of recommendations, depending on what is required, and this forms the basis of a review in which you have up to 12 months to provide the evidence required by those recommendations. The best way to think of this is as a shopping list as to what you'll need to gain your CESR, so it can range from a missing course certificate to demonstrating knowledge across the curriculum. Some applicants have used their original application so they can obtain this shopping list. However, I've seen a number of cases where it's backfired, where it's clear that the missing evidence will take longer than 12 months to obtain. Hopefully, though, you'll be able to pull the evidence together and will be successful. Unfortunately, if you're unsuccessful after this, the only way forward is to either complete a new application, by which time the curriculum may have changed, or to appeal against the decision, although this can be time-consuming and costly for all parties involved. So, as you know, there's a new set of criteria that's due to be introduced from trainees from August 2021. However, the GMC's legal department said that for CESR applicants, this should be applicable from the date of publication of those curricula, which was November 2021. At present, applicants are being given the option of applying under either the old or new curricula, and there are differences between them, notably the introduction of GPCs and SIPs, with a new multi-consultant report to include these. You cannot pick and choose between the old and new versions, but the GMC have advised us that dual running will continue until mid-2023. We're still working on the finer points of how applicants can demonstrate equivalence, given that no trainees have gone through the process. So I'd recommend that you keep the GMC and JCST CESR pages bookmarked. Finally then, here's a few addresses which you may find handy when putting your application together, including Megan, who's my line manager. Just remains for me to wish you luck with your CESR application, and I hope that some of the things that I've pointed out and mentioned will help you towards your CESR. Thank you very much for your time.
Good evening, everyone. I'm Tista Chakravarty-Gannon, and I've been asked to speak with you today about complaints and culture, a view from the GMC. But before we go on to that, just by way of very brief introduction, I have been in and around healthcare for about 20 years now. I used to work with survivors of abuse in the SARCs, the Sexual Assault Referral Centres, and do still to some extent. But it was about 10 years ago I was asked to join the GMC with another colleague to set up a support service for doctors on the ground. And I remember thinking at the time that this was a really progressive thing for a regulator to do. And I was really, really excited and enthused and very keen to join the GMC and explore what needed changing and how we could provide additional support. And at one of my very first meetings, probably just a few weeks into the job, as I was meeting with different groups to learn what we might do differently, I was speaking at a conference and I was invited on to the conference podium to the theme of the Imperial March, Darth Vader's theme tune for those that don't know. And that was a GP conference where I think the organisers were joking, but that moment crystallised for me just what fear we're beheld in. And I completely understand why we are, after all, thought of predominantly in fitness to practice terms, because this isn't a job, it's about livelihoods, it's about vocation. So as I say, I understand why. But as I started to learn more about the GMC and more about our functions, and this slide shows our key functions under statute, it became clear to me that standards there at the centre That is the absolute fulcrum of what we do. And I would argue that actually it's more important for for patient safety than fitness to practice is, because the really, really serious fitness to practice issues apply to such a tiny minority. In fact, in a register of approximately 300,000 colleagues, it's less than 0.025%. And that means the more support we can provide to help colleagues deliver what are complex standards in what is, let's face it, an increasingly challenging environment, and that's prior to the pandemic, well, that is morally, as well as logically, but most importantly, morally, the right thing to do, supporting people to deliver under these circumstances. So it was about 10 years ago, as I say, that we set up what is now known as the Outreach Service. And I'd love to come back and tell you about that in more detail sometime. Of course, it's all on our website, but I am here today, having said all of that, I am here today to talk with you about fitness to practice. And what I thought I'd start with is just a little bit of recent history, which some of you may be aware of, in that complaints increased exponentially over a period of 5 years. And as you can see from this bar graph, they actually doubled in that period. Now, more recently, over the last few years, we have started to see a drop again, but the levels of complaints remain significantly higher, in between 8,000 and 9,000 a year, than they were back in the day, as it were. And some questions for you to just explore that a little bit more. Now, clearly we're not live today, so we won't be actually running any polls, but have a think of what you think the answers might be. So, what percentage of all complaints come from members of the public? I wonder if you guessed B, so 66%. And that means the remaining vast majority of complaints come from employers and colleagues, with a tiny proportion, say, from the police. So, sticking with members of the public for the time being, what percentage of their complaints do you think meet our thresholds to actually go beyond triage to a full investigation? It's actually A, just 9%. So that tells a story straight away. And of course, if members of the public use the website to raise a complaint, they will be directed appropriately. But there is a question, as I say, for the system more widely around how we can support members of the public to understand that there is a real difference between a complaint, let's say, about how the system works, a complaint about, let's say, a low-level communication issue, versus ongoing fitness to practice. So, next question for you. Which of these specialties, or which 3 of these specialties, do you think proportionately receive the most complaints? I'll pause a little bit longer so you can have a think. Now, it's very rare when we are voting live in a room that people identify the correct ones. And I wonder if you did, so I'll share the list with you now. So, top or bottom, I guess, depending on your perspective, is occupational health, and tiny specialty. And we only started to numerically disambiguate these data a few years ago, but prior to that, by far the most complaints for a number of years have been in psych, then followed by obs and gynae, surgery and GP. Then there is a statistically significant drop for all other groups, specialty groups here, which don't proportionately receive many complaints really. And finally, pathologists don't get many complaints at all. And data, as ever, are all very interesting, but the purpose is to learn from data. And for those that are interested, we have a publication out every year called State of Medical Education and Practice, where these data and wider data are available for you to have a look at. And as I say, with data only telling part of the story, we also undertake research around it, and there is really good learning which you'll be aware of, for example around shared decision making in surgery and how we might prevent complaints, from exploring that a little further. So there's a lot of stuff there for those that are interested. But there are some other areas that I want to draw your attention to in the limited time that we have today, rather than delving into that wider detail. And one of those areas that's incredibly important to highlight, I think, is disproportionality. And I'm sure you will be aware, it is well known that there are disproportionate referrals to the GMC. It says here employers make more complaints about minority ethnic doctors. And I'm just going to take you through this top graphic here that's based on place of qualification rather than ethnicity, purely because the data around ethnicity aren't quite as robust, because as you can see here, quite a few people tick the unknown box. But suffice to say, unfortunately, very unfortunately, we are confident that ethnicity is in and of itself a factor as well. But just focusing on place of qualification first. Members of the public tend to complain in line with the register. So you'll see here 66% UK graduates, European, that's EEA, 7.3%, and IMGs, international medical graduates, at 27%. Now that is broadly in line with the register. However, when we look at employers, the picture is very different. And that disparity is significant, which will partly inform the ethnicity, the disparity with around ethnicity, but not wholly, because as I say, we know that ethnicity in and of itself is a factor. And just think back to a couple of slides ago where we saw that members of the public, their complaints, 90% of their complaints do not meet GMC thresholds. As you might appreciate, employer complaints, the majority do meet our thresholds, and that does, yes indeed, mean that the more serious issues that we see that minority ethnic doctors are overrepresented at that sharp end, not just the initial complaints that come in. So what's going on? What's informing that, and what are we doing about it? And yes, clearly we can talk about systemic racism. I think it is important to delve further into that to understand the specific factors that we can tackle as part of the systemic inequality that we are all aware of. And I think there is a wider piece around well-being as well. And I wanted to highlight these two reports to you that you may have heard of. We commissioned them a couple of years ago, Fair to Refer and Caring for Doctors, Caring for Patients. I urge you to at least review the exec summaries of both these reports. I think they are genuinely excellent. And I'm just going to very, very briefly summarise some of the headlines from each of these. So from Fair to Refer, I'll pause so that you can have a quick look at these sort of 6 key findings. And I want to draw your attention to a few of these. That inadequate support, yes, in transitioning, but we see that on an ongoing basis, which chimes, unfortunately, with the whole outsider-insider group dynamic that we see. And I also wanted to draw on the lack of effective, honest and timely feedback. And I have been in conversation with NHS Trust board members who have said to me, yeah, we knew that there was a problem here, but we didn't want to address things. We were nervous about addressing things early for fear of being seen as racist. So that's one dynamic that we see at times, which of course in itself is systemic racism, and then things unravel and get much worse. And it plays to that whole insider-outsider group, cultural competence and all kinds of things. And these findings very much chime with a number of the findings from the Caring for Doctors, Caring for Patients report, where the findings show that colleagues want autonomy, want to feel like they're in control of their role. They want to feel a sense of belonging, and they want to be able to be competent. They want their environment to allow that. However, there are a number of impediments here in the way, from workloads to conditions to fairness. And both these reports make a number of very robust recommendations, yes, for the GMC, but mostly for the system as a whole. And I think that this is really important for us to consider how we work as partners. It's really important for everyone in the system to take a stand. So I was really, really pleased by a recent announcement that some of you may be aware of, where we made it absolutely unequivocal that we were going to take a stand. And at the GMC, we've decided to set ourselves targets to reduce eliminate disproportionate referral and differential attainment in education. And I think that's really interesting because, of course, it's not entirely within our control. It's within our influence, but certainly not within our control, because this is, speaking about fitness to practice for a moment, about referrals coming in. But I am so delighted that we have made this decision, because it means that we are taking a stand. As our chief exec notes here, Charlie, inequality is something that we need to be impatient about, and it's going to need working together to address. Now, we've talked about some very serious issues there, and I just want to provide a little bit of reassurance that, reflecting back on what I said at the start of the session, that we do have very high thresholds. The really, really serious issues that we see that lead to removal from the register do apply to a tiny minority. So bear that in mind, and as well be aware that our thresholds are available for you to review on our website. And if we were in an hour's workshop, we would explore those thresholds, and we would look at more data around types of complaints, types of allegations, where they might go. But I think what might be most useful for this session actually is to look at a case. So I'm just going to put up the details for you. So I imagine you can see what went wrong here. And it's the classic human factors scenario where the EPAC system showed the first X-ray of the day. Mark is being called on, pulled on left, right and centre, and doesn't notice that it's the first X-ray of the day that he picks up working quickly. There are other considerations as well. Where's the pH, the aspiration check? Now, feeding was re-established and the patient died. So, should Mark be referred to the GMC, do you think? Now, hopefully, you've all thought absolutely, unequivocally not, unless there are other performance or professionalism issues. For this in and of itself as a single clinical incident, we're all humans, we make mistakes. This doesn't indicate anything broader than that. Okay. And another question for you, what do you think the missing word here is from Good Medical Practice, paragraph 43? You must what, colleagues, who have problems with their performance or health? Now this is more broad, it's not related to Mark necessarily. The missing word is support. Now, when we often ask this question, the room tends to chorus back, report. And that speaks to a number of myths that there are about GMC, fitness to practice, expectations, thresholds, all of these kinds of things, which I think are really, really interesting, because of course our standard is that you must support colleagues when they are in difficulty. Now that doesn't mean you're abrogating your responsibilities to patients, of course it doesn't. It's not mutually exclusive anyway. So I do find it interesting that there is a perception that the GMC would expect one outcome when actually it's something else we say, something entirely different that we say in our standards. And just to sort of finalise the bits around fitness to practice data and expectations, as I say, there are a lot of myths and I know where they come from and I'd love to discuss that with you sometime. But our aim, where we're at now and have been for a number of years, is to provide early preventative support, whether that is the induction programme that I lead for international medical graduates, whether that is our support programme around bullying, whether that is learning about human factors, whether that is dealing with matters locally as much as possible rather than them escalating to the GMC, whether that is support around health and well-being. And I think Claire Gerarda summed it up really well in an article that she wrote recently, which I've put up there. I'm not going to expect you to read it now, but it's there as a matter of reference, which really resonated with me. Now, in our final 5 minutes or so, I've been asked to speak with you about culture as well, and how that might interplay with complaints with fitness to practice. And when I was thinking about what I might share with you here, as it happens, the day before I'd seen something on Twitter that tickled me rather. And what we see here, this is a ingest. This is looking at the objective distribution of something, where the bad, there are some things that are absolute junk, and where the good, yes, some things are awesome, but actually most things are in the middle as pretty good. Now, the stereotypical American lens that the joke on Twitter was parodying, if you will, was that they will see the distribution as the majority being awesome. The Eastern European lens was much more critical. The British lens was much less passionate, if you will, where everything is fine, whether people necessarily really feel that or not. Then I saw that someone had mocked up the Indian diaspora lens. And this resonated with me. It really did, where this is the good end of the scale. And what it says here is, well, Mr. Sharma's son did it better. And as I say, that really chimed, although I guess it would have been Mr. Sharma's daughter. And in the awesome bit, we have doctor or engineer. And then a Korean mock-up was done as well by a Korean colleague, and that absolutely resonated with a friend of mine who indeed was told, but you only got second chair when she got into the symphony orchestra. So yes, culture does absolutely inform how we perceive things, but culture is broader than just heritage, of course. It's also informed by our family, our schooling. For me, I'm very passionate about music, so the music that I'm into informs my culture. And yes, while some of these things are stereotypes, as I say, the serious point is that that these things inform how we experience things. And going to complaints, fitness to practice, a classic example is insight. We hear about that a lot, where for some, whether it is their family, whether it is their schooling, whether it is a combination of a number of factors, for some it is really difficult to demonstrate insight, which is an expectation when it comes to complaints. And that resonates with me personally, because for a number of years, well, when you grow up in an environment where anything less than 98% is a fail, it is really hard to say, I got this wrong actually. So that's one interplay with complaints. And culture can also impact communication, and there's a lot of training on cultural competence which is really important and can indeed support positive communication. But also another thing that we have to think about with culture is there are some cultures that are absolutely not desirable and that we need to change. And then we've got cultural complexity, social identity, personal styles, which means that well, one person's passionate is another person's anger. So how do we navigate all of this complexity? And I was thinking about this, and I was thinking, you know what? Yes, I'm from the GMC, but genuinely, good medical practice has always been a bit of a lodestar for me. It is the duties of a doctor described therein are often described as a modern Hippocratic oath, and they do articulate shared values for the profession. And when I say good medical practice, it's not just the book in the centre, but all the explanatory guidance with it, which offers, yes, a safety net for shared decision making, for safe decision making, a lever for cultural change, but also importantly, the benchmark for good, safe practice which aligns with shared professional cultural values. So yes, there is a complex interplay between culture and complaints, and the guidance, good medical practice, is our compass to help navigate that. And finally, I want to leave you with a quote which I think transcends cultural complexity and pithily describes something that has much more impact than how you dress or what school you went to or whether or not you play golf or listen to rock music. And that is how you make people feel in those culturally complex environments and interactions. That's what stays with people. So really looking forward to speaking with you. I hope that was helpful. And as I say, yeah, looking forward to your questions and having a bit of chat. Thanks very much.
Well, hi there. Welcome to the BAUS CESR course. I have with me today Mevash, Nadeem, Ashwin, and apologies from Omar, one of our other panel. Thank you for linking into this question answer session. We have managed to collect a few of these relevant questions to the CESR course and try to sort of club them together in this 20-minute session. But if the delegates have any further questions, please feel free to email any of the panel members. Hope you find this useful, and would love a feedback to try and improve this course and the content in the future. So I'll pass this on very quickly to my colleague Mevash, who will start asking the first question to Ashwin. Thanks, Mevash.
Thank you very much, Ajay. So I will start with a very basic question. Ashwin, thank you very much for joining the panel today. So a basic question. So if I am an overseas qualified urologist, or I have no UK experience, and I want to pursue a urology through a CESR pathway, how should I start? Where is the starting point, and how should I go for a collection of evidence?
The best place to go for any information is the GMC website, which has urology specialty-specific guidance, as well as the urology CCD curriculum. And that's the link that if you just Google it, you will get this link straight away. Now, the main thing to remember here is what evidence do I need to collect? And they are mainly in 4 parts: training and qualifications, knowledge, skills, and experience, and 2 new concepts called capabilities and practice and generic professional capabilities. If we take this one at a time, so training and qualifications, this is fairly straightforward normally to get evidence for. And what you're thinking of are CV, employment letters, contracts, job descriptions, job plans, on-call rotas, primary medical qualifications. If you have any specialty-specific qualifications from overseas, honors and prizes and other certificates. Now, what is very important and which is very stressed upon on the GMC website is they are aiming for a 6 to 7 year period over which they want you to demonstrate this evidence. Now, they would prefer if it was the most recent 6 to 7 years, but it doesn't mean that it can't be 6 to 7 years in the past, provided that you have showed that after those 6 to 7 years, every year you have maintained your skills in broad urology practice and not just specific to a subspecialty. If you talk about knowledge, skills, and experience, so if you talk about knowledge, the most important thing there is the FRCS urology exam. Now, of course, there are alternatives to it, and I encourage you to look at the GMC website to look at what alternatives are available. But the easiest way to tick this box is the FRCS urology. You can also show evidence of research, postgraduate degrees, and skills, which are clinical exposure, operative experience, and workplace-based assessments. Now, this can be done in the form of logbook of surgical cases, indicative numbers, research, teaching, service evaluation, and management. Now, if we talk about workplace-based assessments, there are some that are mandatory and some that are optional. The mandatory workplace-based assessments are for the index procedures, which is what we call indicative numbers, and critical conditions that are part of the next 2 points that we'll talk about. And they can be done through various workplace-based assessments, including a new one called the multiple consultant report, which I think Mevash and Ajay will talk about later. And the 2 new concepts are what is called capabilities and practice and generic professional capabilities. And these need the MCR reports or the AES reports. Now, just to talk about what these are. So capabilities and practice, there are 5 of them. Obviously, you can read through them. They're fairly generic. And also the GCPs are 9, which are common to all doctors and not necessarily specific to urology. But these are the things that need to be, that we need to show on the multiple consultant report. So that's the sort of evidence that is needed. And this can be collected either prospectively, if you think that you've got 6 or 7 more years that you want to work, and you want to collect this experience and go ahead. If you feel you already have all of this evidence, you can start putting all of this evidence together and then see if you have a little bit more evidence to collect. Then what you can do is say, plan, okay, in the next 2-3 years, I'm going to get some more evidence, and that'll finish my 6 to 7 years, and then you can submit your proposal. Very important, that 6 to 7 year duration, and also very important to show that you have the whole breadth of all of this there, because anything that you're missing, you're going to lose out on the CESR application.
Thank you, Ashwin. That was brilliant. I'll move on to the next question to Mevash. So Mevash, I'm an overseas urologist. This is another important question that I've been asked. How long does it take for the CESR route, and do I need any UK experience?
So, Ajay, it's a fairly commonly asked question. You will all agree. And Ashwin has covered all the basic stuff we need to know. And if you put all that into perspective, you can understand that this is a long journey. It takes a while to get all the evidence in place, build up your portfolio. Because however, we are overseas qualified and we have all the skills and knowledge, but to get all the competencies signed off and getting an equivalent portfolio as a trainee to prove your equivalence through the CESR pathway, it takes time. If we go by the documentation provided on the GMC and JCST website, it says at least 6 months UK experience. But we all know from our experience and the people around us that it takes somewhere around 3 to 5 years. So if I put my experience into the conversation, so I did it in 3.5 years of the UK practice, so which is considered as a fairly quick, considering other people's experience. So I would say it's not only getting the competencies, also understanding the system, because you are going to step up as a consultant, taking a lot of responsibilities. So if you are completely qualified urologist from abroad, I would say still give yourself somewhere between 3 to 5 years to understand the system.
Very good. Thank you, Mevash.
Right, so I'll move on to the next question. So Ashwin, a question for you. So you have worked as a locum consultant before stepping up as a substantive consultant. Do you think there were some pros and cons working as a locum consultant and working on your CESR application?
That's a very good question, Mevash. So I think the important distinction here is as working as a locum consultant, the only thing that I would advise is submit the CESR application before you start as a locum consultant. And the reason for that is once you step up to consultant level, if for whatever reason your CESR application is rejected, you're going to find it very, very difficult for people to then buy into the fact that you're going to go back as a fellow and gain more experience or whatever is needed to fulfill your application. So the only thing that I would say is take a locum consultant position when you are fairly sure that you have covered all of these areas that you want to cover. Now, compared to a locum and a substantive, I think a locum consultant position is a very crucial step in stepping up. And I found it very good because, going from a fellow to a consultant, you get different set of responsibilities. At the same time, you're giving away some responsibilities. So it's nice to have that freedom, but also have that support from your senior consultant. So that's I found it very useful. And as a young substantive consultant, also, you sort of taking that step knowing you can actually do a consultant job. So if you're stepping up from a fellow to a substantive straight away, you have a lot of doubts. I mean, you may not have it. A lot of people have it. I had it. So doing a locum consultant position, I found that I had sort of a trial run at it for a year or so, and then a substantive role. So I found that very useful.
Brilliant. Thank you very much, Ashwin.
Thank you, Ashwin. That was really useful. A question to Mevash now. So Mevash, the difference between, I'm obviously way ahead. I got my CESR long back before you guys, you both probably did. When I applied the CESR many years ago, there was a lot of collection of evidence and most of it was hard copy copy-based and a lot of time, couple of visits back to my home country, India. How has it changed over time, and are there any key aspects that the applicants need to be aware of?
So that's a very interesting question. So I started off my application evidence collection in 2018, beginning of 2018. And I started off with all the paperwork. And when I was collecting everything, I went back to Pakistan to get some more stuff from Pakistan, which I didn't collect in the beginning. And I started paper application. And then I think around July, August time in 2018, it all changed to electronic. So all evidence collection, submission, and all your application process is now electronic. So it's fairly straightforward. And now your verifier does not need to sign and stamp every single page of your application and evidence. So if, for example, you have got a log, you have got some audit projects and research under supervision of Ashwin, then I will just show the evidence to Ashwin, and there is a verifier a document that Ashwin will just look at, and he will say, yes, I'm happy, this evidence is correct, and then he will sign it off. And you have to get it from all the hospital you have worked in. So you have to get verifier signature from all the trust you have worked in. And even if it is from Pakistan, I included, my evidence was 50-50, so 50% from UK and 50% from Pakistan, and I get a sign from all my verifiers. The other important thing is, when all your evidence is ready, then this evidence goes back to the verifier once again before your application actually goes to JCST, and the verifier look at all the evidence and made sure that this was the exact copy of the evidence you actually showed to the verifier. So there is no loophole in that, and there's a very good triangulation of the process. So it's all electronic now. The other aspect which I would like to highlight is, I think Ashwin has covered most of it, which was about the new curriculum changes. There are three key terms people will listen in future, starting from August this year. One is CIP, capabilities in practice. Second is GPC, and the multiple consultant report. So Ashwin has covered most of it. The gist, what I'm going to highlight here for the overseas qualified urologists, is that a lot of that is going to be now competency based. So for example, when I came in, I knew how to do TURP, I knew how to do TURBT, but still I had to get the indicative numbers of 150 procedures. So if it is 149, I cannot submit my application, although I can do TURBT, but I cannot submit my application. However, it has changed for urology now. For example, if you can do TURBT, and if I can do it, and Ashwin can sign me off, Ajay can sign me off, and I can get this evidence collected over a period of time and maintain my competency, then, and for all the procedures, then I will be good to go. So I don't need any more chasing up the indicative numbers. So that is a very positive point for qualified urologists from abroad. So,
thank you.
Thank you, Mesh. That's very important. I think a lot of people are going to be very happy with potentially not having to do all of the indicative numbers. So I think my next question is to you, Ajay. You've done, like you mentioned, the CESR route a long time ago, and you've gone through a lot of trainees, and you've seen a lot of changes in this pathway. Is there any way that you think that one can shorten the path through CESR?
Absolutely. I think having hindsight is a beautiful thing. And to be honest, I describe the CESR pathway in 4-letter words. Complex can be made easy. Okay. And the thing to do is to break it down, as you've described. Pick one domain at the right time, or one at a time. Preparation, whether you're doing exams or you're doing a CESR route. Try and speak to your consultants, get them on board, have supervisors. The thing is, many people don't realize that they're actually, they're collecting evidence as they're going along, but they don't realize that they're doing it. So they need to start matching well early. If they've decided to go down the path, read the guidance, read the recent curriculum, as you both have highlighted. Have your appraisals regularly, because they will come very handy. They were very useful to me. Most of us have logbooks and indicative numbers. We don't have them actually written down or registered in a proper logbook. We're also introduced through the SAS program, the buddy system, where we are encouraging that try and find somebody who is doing a CESR application. It really, really will help you share the pain and the gains in the future. We have a mentor program. Try and find a mentor, somebody like yourself or Mevash who've done it recently. I'm surely, people will be willing to help you. So there are pathways, and once again, early preparation, early identification, and proper execution, is the way to success in CESR.
Fantastic. I think that dispels of wisdom, very good advice. So I think my question next is to Mevash. In your experience, has the requirements changed in terms of indicative numbers for procedures and TURBs? I know you touched upon the competency sign-off.
Yeah. The one thing I would suggest is there was an excellent presentation by Philip Conford, and it is uploaded on the resort section of BAUS. So I would strongly recommend to go through it. It's very important for trainees and trainers. So one aspect is just the indicative numbers for your basic procedure, core procedures, for example, TURP, TURBT, circumcisions, inguinal orchidectomy. So you need competency. And now the thing, apart from the number, the other thing which has changed is you have to get a competency level 4. So you no more can have a competency level 2 and you can CCT or get CESR. And it is also specific that you do not have to do all subspecialties. For example, if somebody wants to do functional, which is my specialty, I complete my core competencies, maintain those competencies, and then my final year of my training or non-training pathway, whichever I am on, I just focus on that one particular subspecialty. Similarly, for robotic or because what Philip Conford actually touched upon was the subspecialty of uro-oncology, because there are several other sections of uro-oncology. So you have to choose basically which subspecialty you're going in, and then based on that, you can build up on that and get your number signed off.
Fantastic. Thank you very much.
Lovely. Thank you both. That's the end of our Q&A session. And if you have any feedback or any queries, please feel free to email any one of us, and we'll be more than happy to answer. Thank you, Mevash. Thank you, Ashwin.
Thank you both. And if there's any question, please contact us. Thank you very much.
So hi, Ian.
Hi, Joe.
I hope you enjoyed looking at this course. I've certainly enjoyed watching all the talks. First of all, a really big thanks to Mevash and AJ who've put it all together. And I know they've been very well mentored by Nitin Chowdhury as well. And I think this should be a really interesting course for anyone who's contemplating applying for a CESR, but also, for myself as a doctor who supports colleagues who are applying for CESR, it was really good to get some insights. What did you think?
I think you're right. I mean, it's perhaps not a course that people who are with the process feel that they won't be drawn to, but I must say that I think there is something in this course for pretty much everybody. There are some really excellent talks, and like you say, mandatory for anyone going through the process. And actually, I'd go as far as to say mandatory for anyone who's supporting colleagues going through the process, because there's a lot of stuff there we think we know, which
and
maybe we don't quite know.
We advise people when we're not necessarily up to date with what the current requirements are.
Yeah, absolutely. And of course, things are changing, just like the curriculum. And again, that's obviously mentioned. And one of the key things that was brought out, I think, was this idea of currency. In other words, keeping everything that you've got up to date, because there is a time factor involved, isn't there? So you do need to, I think colleagues going through the process and those supporting colleagues do need to be aware that they're being assessed against the curriculum at that time. And they've got to keep all of their data and information up to date.
And you brought out there, one of the key points is this equivalence concept. It's got to be equivalent. So as the curriculum changes for the CCT, so it does for the CESR, because the two processes are supposed to, quite rightly, produce independent consultant doctors in the UK who have equivalent skills, practice, and also equivalent accountability, responsibility, and respect to everybody else.
Yeah, absolutely. And I think both Mark Johnson and Phil Cornford brought that out. And it is incredibly clear. And I think as colleagues go through the course, it will probably be a case of them keep referring back just to keep themselves refreshed up, because of course, like all the courses, is going to be available for the next year or so at least on the platform as well. So yeah, that was a recurrent theme, definitely.
I thought some of the sort of top tips, both from Phil and from Mark, would be very helpful. This sort of concept of the shopping list, very helpful from Mark. He must have seen so many applications in his time at JCST. I was an assessor as part of the SAC, and I've had many interactions with Mark, and he's so supportive and helpful. He really knows his stuff.
Yeah, and I think that sort of reflects the ethos, doesn't it? That the ethos is people want people to succeed. You know, that's why all the advice is out there. That's why this course is out there. There are people there waiting to help colleagues. So the mentality is definitely let's help people get through. They're not looking to trip anybody up. So to have all of that information laid bare in such a very clear way was great. Outstanding. Really good talks.
And a good point from Phil, you know, we talked a little bit about the new curriculum, and it looks like there's about a 2-year transition phase now.
Yeah.
And I think colleagues need to bear that in mind. If people are just got a few bits of evidence to collect, they might want to make sure they get their application in the next year or two, because they're measuring themselves against the old curriculum. And other colleagues who are contemplating applying in the future, they would be well advised to get really au fait with the new curriculum and the requirements, rather than perhaps looking at someone else's old application and just going along with that.
Yeah, I think that's a very good point. That people do need to be aware as to what they're being assessed against. And another thing that Phil did bring up is that the trend is for an increasing pass rate. And I think he said the last year they had figures for was 2018. So to have a 54% success rate is really good. It's definitely getting up there. And so perhaps the message is getting out that it's nice, it's structured, you know, people are getting the right advice. So this can only help that.
Yes, absolutely. I think that increased pass rate, I suspect there's part of it is to do with the networking between colleagues. Certainly, yeah. I've got a couple of colleagues who've recently applied for CESR, and they gained an enormous amount of help from others who've been through the process recently. And hopefully the SAS group that's affiliated with BAUS can be a source of strong support.
Yeah, I hope so. And as we've talked previously, it'd be really great, wouldn't it, for future courses like this to involve colleagues who've been through the process successfully and, you know, can share their experience. That would be excellent, wouldn't it?
And there's probably people who are participating right now. Hopefully they'll be watching this and maybe be ready to share their expertise in the future.
Yeah, I hope so. And I think you're right. There is that ethos of helping the next people through, which is great. Another outstanding part of the course, I felt, Joe, was Tista's talk. I thought that was great. A reference to the Imperial March, when people think about, you know, colleagues in the GMC, I think certainly resonated completely with me. Her
overview is excellent. I enjoyed it thoroughly because, you know, we're senior doctors here. We think we've seen it all. We haven't. But she presented a totally refreshing view of the GMC to me. It was very much about supporting doctors, not reporting doctors. She touched on some difficult themes that, you know, disproportionality of complaints. And it's hard to say that, and even harder to get to grips with it. And things like cultural aspects and just a huge area that so interesting. I really hope we can engage her in BAUS in the future and maybe have her talk to us a bit more about this, because this applies to absolutely everybody.
It does. You're absolutely right. And I think all of us who have listened to this course will probably be taken aback by the fact that there are 8,000 to 9,000 complaints to the GMC a year. I certainly didn't expect that it was that level of magnitude. So there's a lot in there, I think, that would make people step back and think, that's not my perception of the GMC. So it was a really, really great talk. One of the things that I took note of that is when Tista was quoting her, the chief exec of the GMC, saying that we need to be impatient about inequality. And I thought that really struck me that we're doing a lot of that work for BAUS, and that really that resonates, I think, with all of us at BAUS, that we are trying to get this inequality quashed, really.
Yes, absolutely. And impatience is right. We know it's a long road, it'll take many years, but we should be impatient about taking the right steps forward. And I think this, in some ways, particularly Tista's talk, does touch on the widening participation agenda that BAUS is paying a lot of attention to. So I'm grateful to her for giving her perspective, and hopefully she'll be engaged in the chat today and we'll hear some more.
Yeah, I hope so. I'm sure that's the case, and I'm sure there'll be a lot. Obviously, we can't see the chat, but I'm sure there will be a lot of discussion going on while people are listening to everything. So, which is great. That's the whole point of it, isn't it? Get people talking and get together.
So, Ian, as the secretary of BAUS for next year, you'll be taking a major role in leading the development of the conference, and I would have thought you might want to be looking at this type of course and see whether we want to run it again in future years.
Yeah, definitely. I mean, I think, as always, is feedback that we really need for the wash-up session, so we can decide what things to progress with, what things to expand. But having sat through all of this course, I thought it was excellent, really outstanding.
Yeah. So if the participants give us feedback that they found it as enjoyable as we have, and they found it helpful, we're far more likely, obviously, to want to re-engage this group to doing something similar again next year.
Definitely.
Feedback about which elements they'd like to hear more about, and are there any things that we haven't included? I'm sure there are many that they'd like to see.
Yeah, I think that's right. If we could get feedback from everyone who's listening, that would be ideal for us. That would help us. It would help us, evolve everything for next year. So hopefully make things bigger and better as we go along. So that'd be great.
Well, thanks very much for talking to me. And I think it is a bit of a privilege for us, isn't it, that we have had the opportunity to immerse ourselves in a course that perhaps we wouldn't naturally have been drawn to. And it's been really insightful and educational.
It has. I really enjoyed all of it. It was really good. And I've enjoyed chatting with you as well, Jo. So thanks.
Thanks, Ian.